Well, good afternoon. I am back in the office catching up on some work here. I did, for the past several weeks, take time away from seeing patients in the office until this past week when we decided, with things happening statewide and nationally, that there may be some room to start cracking the door open just a little bit. I wanted to catch up on issues that have been happening both regionally as well as nationally, and some of the conversations that have been happening with peers of mine in family medicine, as well as those who have been tapped for their expertise in public health quorums to possibly help answer some questions that I've been getting quite a number of, both via my telemedicine portal, phone calls, messages, emails. Many of us, honestly, in the same boat as this has been a quite the time that has tested a lot of us, both with challenges from all walks, economic, social, emotional, health-wise. So we, as a community and a country at large, have had to face challenges. I can only speak for myself, but it's been a very challenging time at the home front as well. So first off, I hope to put this out there now to help maybe defray some fears, and some questions might get answered along the way. And I do hope this does find you and your family healthy, dealing with the shelter-in-place rule, which will still be in place for a while, I can only imagine. I don't want to get into politics. I have a number of colleagues that are doing a good job at digging into finding out how we can best solve this problem. I'm trying to focus more on moving forward day by day and not looking in the rearview mirror. Nonetheless, I can only imagine many of you share concerns that have occurred over the last several months, and now I think the benefits, maybe the silver lining, might be looking at how this transpired, how this all came to be, and how we can do a better job, both as clinicians as well as a society, with the help of our public health officials, to be ready and be able to do a better job come fall and come years down the line. I found a quote by Malcolm Gladwell that says, "Look around the world," or I should say, look at the world around you. "It may seem like an immovable, implacable place. It is not. With just the slightest push in just the right place, it can be tipped." And I think that is what's happened, obviously, to many of our lives, and unfortunately those who've fallen ill or worse, but how something so tiny and so seemingly minor can have such a profound effect. Several in the field of public health have commented how we have not seen anything like this in the scope of a very complex world. Some comparisons, of course, to the Spanish flu back in the late 19 teens, but we are now in a much more highly complicated, technologically advanced world where travel, international trade, the list goes on and on. How much more complicated we as a society are now, and how such a tiny virus can scuttle the whole ship, and how can we adapt to that? I thought this was a segue into a conversation I've had with many of my teachers over the years. This is a lesson of being comfortable with change, but also one of groundlessness, feeling like there's nothing underneath you, something that we don't do well with as a species. We want something to be definite and concrete. We don't like uncertainty. When things feel uncertain, when we don't have answers, that's what tips into an emotional cascade of emotions, from fear to anger. I've seen it out in the community. I've heard it online. I've had it in front of me in a telemedicine interview more than enough times to realize it's really affected a number of people in many different ways. Very normal, very expected, but our society has not seen something like this, nor has it seen a forced shutdown of this magnitude for a long time. So this in and of itself has led to Fear Factor 2.0, leading to conspiracy theories from one end of the spectrum to the other. I'm going to save that for another discussion, but it's understandable where a lot of that fear originates and why those who have taken it upon themselves to spread false rumors, spread research findings which have no scientific background. It's understandable where it comes from, and to reach out to those people, as one of my colleagues says, with love and not with hate, is probably the best thing we can do right now. I'll share a quote, and this is one of my favorite books in times like this to refer to, but one of Pema Chodron's books quote says, "When things fall apart and we're on the verge of we know not what, the test of each of us is to stay on that brink and not to concretize," meaning not to make things concrete, making things definite, making things understandable. And I think many of my colleagues in public health and those I've been tuning into with podcasts and reading journal articles in the past several weeks have pointed out we're not good with uncertainty, and we've got to be mindful of that. Daily updates. I wanted to give you some updates of some conversations I've been privy to as an Academy member of the American Academy of Family Physicians, and most recently conversation invited the likes of a public health official. He is actually the head of the public health department, the Association of State Territorial Public Health Officials, Marcus Plescia. And his job is to interface with government, banks, federal governments, state governments, and public health offices all across the land, which has got to be quite a challenge these days. He's also a family physician, but he's been doing public health predominantly for the past 5 years. And some highlights of that discussion: a bank of clinicians that were invited to talk on the concept of opening the doors, if you will, or opening back our economies, opening, and how does that look from the minor steps to the more major steps of what retail outfits, what businesses are going to be allowed to resume business, what practices are still needing to be shut down and why. And across the board, obviously, lots of heated debates on that topic. I did want to mention a few high points that stuck with me. One is the importance of still wearing a mask when you are out in public. As a family physician and as someone who has dedicated his life of nearly 30 years, the concept of keeping one another safe and protected has got to be paramount. And at this point, though in Oregon, and granted, knock wood, we in Oregon have seen lower numbers than in other parts of the country, fortunately, for various reasons, but I think we can't get too cavalier. I understood from a friend telling me that Costco, as one vendor, has required now that their patrons enter the store with a mask or else they're not allowed in. That's created some pushback on some patients that I've talked to who don't think that that's fair. But my comment is in line with Dr. Plescia's, which is, for the time being, when we're out in public wearing a mask, I agree, sends a signal that I'm taking care of my own self, but I'm also doing my best to take care of the rest of the community until at least we have a better sense of numbers. And that gets into the discussion about COVID testing, antibody testing, that I'll get into a little later. But I wanted to just say, for the moment, wearing a mask when you're out in public sends a very strong signal, and folks will take message that is, and I'm talking about places of business, I'm not talking about out in the middle of nowhere where there's nobody around, but this is particularly when we're around other people in retail outlets, grocery stores, and the like, when we cannot always maintain that 6-foot social distancing requirement. The other where are we now, I wanted to bring to attention, which I had in a previous email announcement for my own practice and for a number of my colleagues around the country in family medicine and integrative medicine, is we've taken some steps to accessing our office in a live platform, but yet we're still maintaining most of our contacts via a telemedicine portal, because as Dr. Plesha pointed out, the key to keeping this viral spread down is to keep contact opportunities down. So it still does not make sense to open a practice up completely and have everyone walk in and do everything like we used to do. We're not going to return to that anytime soon. So his emphasis was make sure telemedicine is a rolled in part of your practice, and hopefully, I hope it continues to be this way, where I can offer that service to my patients on an ongoing basis, especially for many situations where consultations do not require somebody being in my office. We need to make sure that our third-party payers are in agreement with this, but as many who have already taken advantage of this service have commented to me in our interviews, I love this. This is a wonderful way of me not having to risk coming into the city or into a medical office. I have some traveling from half hour to 45 minutes away, where we can accomplish a great deal in the telemedicine portal. So we want to maintain that. We have some who I just simply cannot ascertain the condition or the problem. I don't think they need to go to urgent care. I don't want to burden the healthcare system by sending them to the emergency room if they don't need to. So there are many things that I've been able to triage in my own office, but with that, the agreement is that the patient will be triaged, we'll have temperature checked, we'll have a questionnaire filled, formed out. The idea being that we don't want to have sick individuals or those who have been recently in communication with those who might be ill. We don't want them coming into the office. For those, we'll do telemedicine until further notice. Also, if those folks do take the option of coming in for an office visit, we want to make sure that they are the only ones in the office as much as we can. We don't want a lobby full of people. We're asking folks to stay in their vehicles, or they may be the only one in the lobby. I'm exploring the option of having my front desk staff be working remotely and not even in the office, taking care of most of those things via telephone messages, telephone calls, text messages, and much of that can still be accomplished without a face-to-face contact to keep them safe and to keep my patients safe. Bringing the least amount of extra stuff, if you will, into the exam room. I'm trying to do my best to work out of one exam room with frequent wipe downs and keeping surfaces clean, and in between cleaning. But when patients come into the exam room, if they're bringing a ton of their own personal clothing and bike bags and backpacks and such, as much as I can ask, leave those in the car, leave those at home. If you want to bring in a water bottle, that's great. But for the time being, we're asking that folks minimize what they bring in. If they absolutely need a caregiver, they're certainly welcome, but we're trying to keep it to one person in the exam room with myself or my medical assistant. I've had a lot of questions about testing, and I'm sure there's still a lot of questions that I don't have answers to. It gets back to one of the conversations that we as clinicians have been often asked, what do you do in a certain situation like, and we're expected to always have the answers. Well, we know better than that. There's a lot out there we don't know. And to get comfortable with the response of, I don't know, is what many public health officials are having to grapple with, and be honest with the fact that there are so many unknowns that we are still learning about. The good news is we are still learning about. But do realize and do understand that despite all our advances in modern medicine, in science, and research, there's still an awful lot that we still don't know, and this is a learning experience for all of us. So please understand if we don't have all the answers. Please don't rely on Dr. Google. Please don't rely on government officials. Please don't rely 100% on the CDC or any government agency that's being taxed to the limits. But let's make sure we work on this together. If someone has classic COVID-19, SARS virus symptomatology, which has been published, which has been on my website in a previous blog and newsletter, the most optimal thing to happen at that point is to get what's called point-of-care testing. Have that patient go to a approved test site where they can get the proper swabbing collected, and that person gets the test results as soon as possible and is told at that point that if they do have a positive test, they must self-quarantine. That is the optimal. The problem, as you already know, is the availability of those test kits. Now, they've become more available, but I would remind us all that there are regions and states, counties, towns and cities across the country who just don't have adequate test kits. And not only that, but the labs where those test kits are run have been running short on viral auger and other solutions in order to run the test once the lab has those swabs in their possession. Something that many of us don't realize why it takes so long sometimes to get test results back. Those are some of the limitations with actual testing. So they are reserving most available testing for those who qualify. And we haven't yet got the amount to be able to do universal testing on everyone. We hope that that day will come. Again, that gets into another issue I don't have time to get into today, but has been in the news. The other, now that many who have been either exposed or are needing to get back to work, the question now has been asked about, well, what about antibody testing? If I've been exposed, can I get antibody testing? I think the comments made by the public health officials have been ones of caution, mainly because there is a statistical difference. Just not to get boring, but when we talk about tests, when we talk about medical tests, these tests need to be highly specific and they need to be highly sensitive to pick up a disease when it's present. The problem is that some of the testing that's been done has been with tests that got pushed through the FDA quickly and haven't necessarily had the best sensitivity and specificity to be what we would consider to be a good quality test. So, for example, when we're talking about antibody testing, most experts that I've heard talk to this topic insist on what are called ELISA antibody testing. And those are usually in approved, accredited labs that have the availability to run that specific kind of antibody test. There are those on the market that are available from Amazon to imported test kits that you can buy online, referred to as lateral flow immunoassays. Those are not recommended at this time as far as my reading. As time goes along, this may change, but they have not shown to have a very high specificity. So you might get test results back that aren't that reliable. Then what do? That's the problem. The interesting thing is if you are in a zone, a hot zone, or a high prevalence rate, example would be New York City, and you were to run an antibody test on an individual or do testing on them to see if they have antibodies, the testing actually turns out to be more reliable in a highly prevalent area like New York City. Whereas, just statistically speaking, if you are living like we are in a low prevalence area of the SARS virus and COVID-19, in an area like ours, running tests like this actually may be very misleading, may provide more false positive, false negative test results, which aren't going to be very reliable or helpful. Beyond that, we're finding, as has been reported, patients known to have had COVID-19 hospitalized, symptomatic, even those sick enough to be in ICUs in China and in the European theater, have been later tested and found to have their antibodies not be positive. What does that mean? We don't know. And again, we're getting into that uncertainty. And to do universal antibody testing right now, to my understanding, we're not quite there yet because of these limitations in testing, because of these limitations in where the testing is being done and what patient population you're talking about. So I would consider that to be a work in progress, but I wouldn't be rushing out and getting antibody testing until we know more and until we look at populations differently. 2 comments, and then I'll come to hopefully a conclusion. One is I was struck with the fact that just the fact that if you were implementing social distancing all by itself, keeping folks that were known to be sick in social distancing or self-quarantining, shelter in place, that reduces the spread of the virus by 30%. That's a heck of a public health step in the right direction. If on top of that you had someone who did test positive, was told to self-quarantine, and they do, and on top of that, so that's 30% reduction right there. On top of that, if you do what public health departments are good at doing with the right amount of manpower, what's called contact tracing. So that's finding out all the people that has had adequate or enough exposure to that person who had the actual virus. If you do social distancing plus contact tracing, finding all those social contacts, and then quarantine those patients, those contacts for the adequate amount of time, you've reduced the exposure and spreading of the virus by another 30%. So by simply taking those folks infected or suspected to be infected because of lack of testing, and on top of that, getting in touch with those people who are in touch with those sick people, you've dropped the spread by 60%. So that's a tremendous jump in the right direction until we know more. Now, people have also asked, well, what about this concept? Maybe we'll get a vaccine soon. Folks, this isn't probably going to happen for another 18 months. And it isn't so much the issue about the fact that we don't have scientists and labs and research and development in order to come up with a virus, or a vaccine, excuse me. The problem is production. We're talking about a vaccine that would need to be mass produced for folks all over the world, not just a certain subset of the population, not just folks over 65, but a universal vaccine. And that takes a lot of time to be able to produce that much vaccine. That's a wake-up call. Some have commented we may be more likely on the horizon to develop a antiviral medication sooner than we'll see a vaccine. But that too, we'll have to wait and see. Many are now rethinking, well, if I didn't get a vaccine for my flu shot last year, what I might rethink and reconsider that this fall. We're all going to have our opinions about this, but the harsh truth is that a fair percentage, 25 to 30% of the folks found to be infected with the SARS virus had a co-infection with influenza. So it might retool how we think about flu shots compared to how we were thinking about things in the past. We don't know if this is a co-infection because of the SARS virus, but I would suggest that we may really need to look at this again in a little bit different context when fall flu season shows up and really look at the abilities to protect people from potential hospitalization and ICU visits by getting their flu shots done. One thing to remind us all is, no, this is not the only problem that's winding up in the emergency room, although listening to the media, it sure sounds that way. Don't forget that there's folks that still are having issues with heart disease, cancer care, issues like strokes, issues like traumas, sprains, strains, broken bones, all other manners of emergency room visits. Emergency room directors are quick to make sure that we as family docs remind you, don't avoid the ERs in cases like this. ER settings have taken those steps to make sure that you stay safe. So if your loved one has an emergency, they don't want you avoiding the emergency room. They want you to get the care that you need, that your loved ones need. And if question whether or not to go, contact your PCP, because that is something that has happened around the country. People are not going in waiting 3-4 days after they've had a heart attack. So we don't want to have that happen. With that said, I want to conclude by wishing you all safe, healthy days ahead, realizing this has been a trying time for all of us, healthcare providers included. But we hope that with additional information, as we learn more and more, that we can start to be a little bit more free with movements, but understand why some of the decisions have been made from agencies around the country to try to keep this from spreading and keep that curve, as they say, as flat as possible. I wish you a very good evening from Eugene, Oregon, and hope you are all well. And I thank you for your attention. Take care. Bye-bye.